The next session will be on plaque modification. This session will be chaired by Dr. Sukumar Ghosh, Dr. R.S. Joshi, Dr. Binayak Dev, and Dr. Chandan Misra, and moderated by Dr. Sanjeev Kathuria. The expert panelists for the sessions will be Dr. Shilanjan Roy, Dr. Ritendra Talapatra, Dr. Ovik Karok, and Dr. Rajiv Krishna. It is over to you,
Dr. Dhani will not be there. So
yeah,
Dr.
Dhani speaker will not be there. So, I would request the other speakers to make up for it.
Good afternoon, everybody. I think this is a very interesting and a very important topic of plaque modification, because new things are coming up very in the armory, and we have various options to now take care of plaque. Maybe a decade back we had only Buddha. Now we have an armamentarium of different balloons. Interesting to go through all of them and understand where they are placed right now in our fight against the plaque. Over to Dr. Mandal sir first to please give a talk on cutting balloons.
Good evening. Am I visible? My slides are visible now?
Yes, sir. Kindly change the slide share. Full slide
yes.
mode.
Go to full, yes. Yes. It is in full slide now?
Yeah, it is okay.
Is it full? Yes.
Yes.
So we are starting with the coronary plaque modifications, and my talk will be restricted to cartilage. So if there is an ISR lesion, osteal lesion, bifurcation lesions, and fibrotic lesions, calcified lesions, these four groups are the areas where my balloon can work. One is to avoid slippage, avoid back seat, and also change lesion compliance. That means from that point of view, we can go ahead with some cutting balloon or angioscalp or scoring balloon. These are non-compliant balloons with cutting cones or Ryerson balloons to score plaques. That can be angioscalp, cutting flex cone, or newer Wolverine cutting balloon. And score flex is a semi-compliant balloon, dual where exact focused inflation force and facilitate control plaque fracture and creation of focused force in localized region of the plaque. Why cutting balloon is helpful over COVA, that is common balloon. Cutting balloon mechanism achieves movement gain primarily through plaque compression and less wall vessel expansion. That means there is more of redistribution of plaque, increase in vessel area and decrease in plaque area. And plaque compression is there and the axial redistribution. Whereas in common plain balloon expansion, increase in vessel area, reduction in plaque area. Vessel plaque compression is moderate and axial redistribution is much more than in cutting balloon. So it creates a control incision planes which help relieve hook stress and allows dilatation at low pressure. This is the images after angioscalp, and that shows fracture of the most of the areas of the plaque, and greater surface area of the rectangular retinal make the force focused on the lesion similar to the standard COVA balloon. But this can fracture the plaque more easily at low pressure. OCT images of a cutting balloon, the combination of the cutting device, non-compliant balloon material, and arthrochrome blades resulted in reduced vessel stretching and injury by scoring for precise dilatation and maximum movement gain by a plaque compression using low pressure. So cutting balloon, when to use? One area is instant restenosis lesions, avoid balloon slippage. Osteal and bifurcation lesions, avoid plaque seat. And fibrotic lesions changes lesion compliance. For calcific lesions, it is now getting limited over day by day with IVL and advancement of rotor technique also. But IVL is shifting our area, that is cutting balloon is less used in calcific lesions. So fibrotic and lesions and instant restenosis, osteal and bifurcation lesions, and also in small vessels we can use cutting balloon. These are the indications. Lesions should be discrete or tubular up to 20 millimeter. Reference vessel diameter should be 2 to 4. light to moderate tortuosity of the proximal vessel segment, non-angulated lesion segment, absence of angiographically visible thrombus. Contraindications, avoid passing through the start of previously deployed stain. That's a good warning point, and deflated balloon could become entangled in the stain on withdrawal. When treating bifurcations, cutting balloon can be used prior to placing a stain, but not taken through the side cell of a stain. So this is a warning things that to be kept in mind. This is a case example of a ostial and also can be said as a bifurcation lesions. This is a patient in whom I have done a primary angioplasty 4 years back, came back with a critical lesion in the ostial L6. The previous stent was from ostial LAD. This common balloon failed to hit the lesion, so I have to use a cutting balloon of 3/6, and after study that shows a good result. Here you can see as a critical ISR in a patient with PMS stent implanted 20 years back, 2001. I've used Wolverine balloon directly. It is having high crossability, goes through the critical lesions and dilated well and stented with a 3.523 Giants expedition stain. What is the utility of this Wolverine over Flextome? Reduce non-functional blade height to improve profile and reduce cast pad height and wide to improve profile. It can go through like a common balloon, and its height is also too much. All sizes starting from 2 to 4. Here I have used 3, so it has got 3 atherotomes. If it is more than 3.25, it has 4 atherotomes. Up to 3.25, it is 5 French compatible, and after that, it's 6 French compatible. Nominal pressure is 6 atm like other cutting balloon. Rated mass is 12. So Wolverine has got a lesion entry profile that is lowest till the balloons are available, cutting balloons. This is another case example of an ISR. There is a stain in the LAD that shows diffuse ISR. Apparently, that looks to be non-critical, but I have done FFR because the patient was too much symptoms. FFR came out to be 0.73, and in 2 points, it looks very much critical. This is a OCT run before ballooning that shows at 2 points there is a too much of intimal tissue proliferation with luminal loss. This is the Flextome, 6 into 6, and after balloon dilatation, this is the post balloon result. Well cut lesion area. You can see here also. So this is the finished image views after ballooning that shows this plaque is well cut and it is afterwards treated with the 3.538 Giants expedition stain. This post dilated, and this is the final result. This is the final OCT picture that shows well opposed stent, and on around 9 months follow-up, the patient is well now. Bifurcation, nice study shows the cutting balloon angioplasty effectively facilitates the interventional procedures and lead to a low rate of instantaneously restart. Cutting angioplasty did not reduce recurrent ISR and major adverse cardiac events as compared with conventional POVA. Am I audible to everyone?
Yes,
Hello?
you are. Yes, you are, Dr. Mandal.
Yes. Because the other videos have got off, so I got scared that.
No, you are very much audible. Thank you.
Yes, a timer is also not going on. That's creating confusion. It is 9:42 still.
You have 1 minute left.
Yes, I will finish. So how to use cutting balloon? Some of the warning points: selecting diameter, balloon to artery ratio should not exceed 1.1:1. In vessel, more than 3. For vessel 3, 1:1 is more appropriate. If using numbers, measure media to media and not maintain 1:1 balloon to artery ratio. That is very much important in selecting the diameter of the balloon and length. Shorter length is easier to deliver, but with Wolverine, I think deliverability has been overcome. It's a highly deliverable balloon. In my experience in last few cases, how to use? Ideally, guide pack should be 6 step. Guide wire moderate should be there. Hydrophilic coating may be here. And regarding data, regarding cutting balloon, reduced clinical trials, winner registry, nice start, race start, but also it is a safe. But there is a not too much of advantage regarding mortality or repeat ISR or to common balloon angioplasty. Procedural benefits are some there, relatively simple to use, cheaper than laser and rota, limited indications for use, for resistant fibrotic lesion, instant restenosis, and finally calcified vessels. That is becoming a question now, but can be used only in mild to moderate calcified arteries with vessel toxicity to favorably alter vessel compliance. This is the summary of this. I am covering just left part of this screen, that is non-compliant balloon cutting and scoring. Rest has been left over for my next speakers. So we can take up questions now. Thank you. Thank you for patient hearing.
Thank you, Dr. Mondal. I have a couple of questions. One is my concern for use of cutting balloons in small vessels, which you mentioned. That's number one. And number two is, in the scenario of where IVL is available, in which scenarios would you use cutting balloons and not a IVL?
Actually, for IVL, it is a calcified lesion. That means if the arc of calcium is more than 270 degrees, thickness is more than 3 millimeter, or it is the length is more than 10 millimeter, then we have to use IVL. Otherwise, we can selectively go with cutting balloon. But vis-a-vis, there is no comparative trial between IVL or your cutting balloon. Itself, there is no randomized controlled trial, that is recent controlled trial with cutting balloon. That's why I have told this, my talk will be on old data. There is no vis-a-vis data in compared to cutting balloon or IVL. I think with time, IVL is taking over this cutting balloon. Day by day, we are limiting our use. Even rota is getting somehow replaced in calcified lesions by IVL. So it is a changing scenario, not that my word is a fixed word, so that it can be treated with cutting balloon. But ISR lesions, I think ISR lesions will be a good indication also in future for cutting balloons.
Yeah, thank you, Dr. Mondal, for your excellent presentation. I think we can move on to our next speaker, Dr. Hiramat. He'll be talking on IVL. Dr. Hiramat, please.
Good evening, everybody, and thank you for this invitation. I think since the birth of angioplasty in 1977, the angioplasty has advanced immensely. This is the first gentleman who had an angioplasty. To celebrate 30 years of angioplasty, we invited him to Mumbai during our CAD meeting. And these are the two gentlemen who were involved in the first angioplasty, Grunzig and Berniemeyer. So when we talk of hard lesions, CT angio sometimes helps us to decide. This is one case where the operator has not prepared the bed and put a stent, which fails to expand with whatever you do afterwards. Both FFR and plaque vulnerability can be combined when you sort of analyze the data together. And CT coronary angio, I think as an angioplaster, we must take a relook at this modality to decide what can be done as the best strategy. So the CT and IVUS in a CTO recanalization can be combined to plan your strategy. So the strongest indicator we have for calcium is the rotablator. And now we are talking of the shock waves coming out of this balloon. So this is a calcified vessel you can see on fluoroscopy, and the lesion is actually in the mid-LAD. And this is a rotablator, which we all use for calcified lesions to get a good expansion of the stent. So this was actually a LAD, a very tight lesion at the bifurcation, which was attempted outside, and they gave up because this balloon would not expand further. So in this case, we did a rotablator, and we did a flex storm cutting on the diagonal side branch. You can see calcification at the bifurcation extensively even on fluoroscopy. And this is how we get a good stent results. So these were some of the steps which we did, rotablator and the flex storm. This is a left main trifurcation. The patient was actually placed for surgery. However, as the date came close, he took a discharge, and he's with us in the cath lab. So this is a left main trifurcation, including a very tight lesion at the diagonal mouth. This is a zoom image for you. So everything was prepared. We have a pulmonary artery catheter, a long sheath, aortic balloon, and patient was on ventilator. So first we did rotablator with a single wire towards LAD. Then we used OPN-NC towards circumflex, then OPN-NC towards LAD, then NC to the diagonal. And first stent was placed in diagonal. Then the second stent was placed as mini crush to LAD, and third one going from left main to circumflex. All had rewiring and a kiss. So we ended up like this: first stent to diagonal, mini crush, second one to LAD, and the third one left main to circumflex, which was a very dominant circulation. So this is how the stents were placed. Final kiss was done, and you can see a nice result. So the balloon has got now something very special for us. Like, this is a 65-year-old lady, diabetics. She has a kidney disease, and or she's clearly overweight and low ejection fraction. And she had severe angina with 3 admissions in previous few weeks. So these are the typical diabetic small diameter vessels and critical lesion at the ostium of the LAD and the circumflex. The circumflex was a big size circulation. Then we had to prepare her. You can see a balloon pump, aortic balloon pump, a Swangen's catheter to monitor PA pressures. We used a long sheet for more support, and we had a temporary pacemaker in case she goes into bradycardia episode. So the bed was prepared, the 2 stents were placed, and the part was done, and this mini crush was achieved. So all this went very smoothly with no any kind of hiccups. So something was booked for surgery. I thought surgery was also a good decision considering the vessel diameters, but had a nice result with this IVL balloon. So you don't have to withdraw the wires. Like if you had to do a rotablator, we can wire one after other. Then strategy we adopted was mini crush. So the side branch stent was guaranteed in this very, very sick patient. And this is another case where we have circumflex, very calcified lesion and very important left circulation. Again, we used an IVL balloon. It needs a little, it's little bulky. It needs some balloon preparation before you can take it there. And the length is always fixed. The diameter you can change from 2.25 to 4.0. This stent is placed from circumflex ostium, post-dilated, and you can see a nice final results on this patient who was very high risk. Another case who had lots of calcium in the right coronary artery as well as LAD. We had actually planned to do RCA with an NC balloon and LAD with a rotablator. However, nothing worked on this tortuous, very critically diseased RCA, which was also dominant circulation. So we actually had to use a rotablator. During rotablator, we had slow flows and distal embolization needed a lot of time. So the RCA to get this kind of result itself took a lot of time. So when we moved to the left, instead of using a rotablator, we used a cutting balloon. This patient was quite sick and we didn't want any distal embolization. And you can see how much calcium is there. This is an IVL, and you can see an excellent expansion of the stent at the LAD ostium. This was another case. Lima was the only graft which was patent. However, the patient had critical lesion beyond the Lima. The Lima was also supplying the RCA retrogradely. So very important. This is the occlusion of distal RCA, and here we used these two stents, and you can see the not only the LAD is opened up, but it's giving huge collaterals to the occluded PLV distally. This was another Lima graft, which was completely destroyed. Patient had previous stents in the LAD, and this patient, you can see how much is the achievement. Left main is diseased, LAD is total, circumflex mouth is total, and with this kind of balloon expansion and stenting, we could get complete normal flow. So when we talk of calcification, we all know that rotablator can give you an excellent result for calcium, which is from inside. If you have a deeper calcium, however, this shockwave balloon becomes very useful. And you can actually combine the two for inside calcification. After imaging with IVUS, you can use a rotablator, and then you can do a rotatripsy with a calcific balloon. So this is one thing which is new to us. We are all learning, but I'm sure something which is very useful in the cath lab and can give an excellent stent expansion. Thank you indeed for your attention.
Thank you, Dr. Hiramat, for your excellent presentation of using multiple modalities in calcific lesions. One question, this IVL being an expensive modality, number one. Number two, because you have limitations of size, how often do you actually image before you actually decide on using IVL, number one? And number two, in cases of calcific nodules, I mean, what would be your way of dealing with it vis-a-vis IVL balloon?
Yeah, I think calcific balloon, calcific nodules are a problem. I don't think any one of us has really solved the problem to the fullest. So everybody keeps going by his own experience. So I would still feel it's something which is very, very difficult to address. I mean, we all try a big size cutting balloon, then IVL can be an option. But I think there is no one single technique for calcific nodules.
How often do you image in your lab before you use these kind of modalities?
Oh, I think our image for calcification and choice of modality, imaging is very high percentage. We are imaging probably more than 75% before we make a choice in this kind of cases. The rotablator does a very good job if the calcification is along the inner lining. But if you have deeper calcium, you need something like IVL balloon. And if you have both calcification along the lumen as well as deep calcium, probably rotatrips is better, where you combine rota and then bring in a IVL balloon.
Any more questions from our panelists, please?
Can I make a comment, sir?
Yeah, sure.
With respect to a calcified nodule, I think the only modality which might work is a rota ablation. That's the only one which has been tested till date, not tested, but that's the only one which has been found. An IVL for a rota calcified nodule might be that good an option. Trying a rota ablation will be a first option.
I mean, rotablation is one of the options, but I would still think it does a good job for a nodule which is very eccentric, and rotablator would probably go from the side and not really cut the hard calcific lesion.
Probably need a wire bias for that.
Wire bias is yes.
Can I make a statement?
Yeah, sure.
See, calcific nodule you should divide into two, one with 360-degree arc of calcium and one without 360-degree arc of calcium. If you have a calcific nodule alone with 180 degrees of arterial wall without no calcium, then I think it is more difficult proposal rather than the first one. In the first one, as you said, wire bias is there, then rotablation will work with 360-degree arc of calcium. You are not going to injure the normal vessel wall. But if you have a 180 degrees arc of normal vessel wall and a calcific nodule, your rotablation is not going to work. Your cutting balloon possibly will not work, or an OPN balloon will not work. If at all something will work without any damage and without any sacrifice to safety, is an IVL balloon. But the first statement Dr. Hiremat made is the most perfect statement. There is no ideal solution. Even orbital atherectomy, which we saw in some live demos, is also not a solution when you have 180 degrees normal arterial wall and a calcific nodule. I mean, that also leads to more complication.
I would feel that when you have a 360 degrees calcification, we should not call it a calcific nodule. I think.
Why not? If it is protruding inside the lumen, it is going to be a calcific nodule. It will be called a calcific nodule. You can't call that as just a circular calcium. So I think it is described, well described in literature.
I think typically when we talk of nodule, we are talking of an eccentric. Yes.
Eccentric. Yeah, eccentric. So that's what I'm saying. So arc of calcium with eccentricity and without eccentricity.
Dr. Hiremat, can I ask you something? When you are actually dealing with this deep calcium, I mean, would you be doing more of OCTs rather than the IVUS to determine?
IVUS not very good for deep calcification.
Yeah.
So there, I think we need to move to the new modality, the OCTs, and IVUS will probably be telling you a lot about the calcium along the lumen.
What about laser for this calcific nodules? Hiremat sir?
Sorry, I didn't get your question.
He's asking about laser.
Laser atherectomy for this calcific nodule.
No idea, but I think laser, if there is a total occlusion with calcification, I think laser would be very good. But just for calcification, I'm not sure, but I don't think it's useful.
Thank you, Dr.
So we have Dr. Sanjog Kalra also, I believe, and he has to make a statement about laser in calcific nodule. He has written on the chat, it doesn't work, but I think we should take his statement. Dr. Sanjog Kalra, is he there?
He's there.
Hi, how are you? Thank you very much for having me.
Yeah, fine. So,
Hi, Sanjog.
How
Yeah,
are you
make a
all? Thank
statement.
you.
Make a
Thank you,
statement. You
Dr.
have
Hirmat, for
almost all
your
the
talk.
modalities with you. So
So
what is-
calcific nodules for all of us, just as Dr. Hiramath pointed out, are a problem. They are not treated well with any particular modality. Amongst the ones that that was mentioned was laser. Laser's primary mode of efficacy is actually dependent on energy radiating outwards within the acoustic bubble collapsing to create a refraction wave that goes forward. So generally the laser has its activity in circumferential areas at the tip and then forward from the tip. Because of the nature of how nodules are and the fact that the eccentricity actually directs devices away from the nodule and the majority of energy is pushed forward, laser is not an effective modality with or without contrast enhancement. For that particular problem. That is a very different problem than, for example, an impenetrable proximal cap or an eccentrically calcified lesion where things won't cross. Because in that case, even if your laser catheter doesn't necessarily move forward, you've still provided some ablative energy towards the tissue in front of you. And in that case, you can actually start to deliver devices. We see that a lot in CTO PCI.
Thank you, Dr. Kalra. I think calcific nodule could be a huge topic to discuss, but for constraints of time, I think we should move on. Invite Dr. White Shah for his talk on OPN use and limitations. Over to you, Dr. Shah.
Yeah, thank you. Let me see if I can get the right slides.
Yeah, you got it.
Got it?
Can see
Thank you.
Yeah.
Yeah, so just a second. Let me go to the first slide. So my presentation is not going to be as exotic as Dr. Hiremat's. It will be plain, simple, and short. So we are talking of plaque modification with OPN balloon. And basically, our problem with calcified lesion is to either under expansion or malapposition, and both have increased rate of MACE. And this is the standard protocol which has been proposed by Carlo Di Mario 2019. In balloon non-crossable, of course, rota, laser, and orbital. But if it is balloon crossable, then you have, and in both the diagrams, algorithms, he has said that optimal balloon expansion. So at 2 or 3 places, either before or after rota, optimal balloon expansion is there. One of the options Dr. Hiremat said is IVL, but cost limiting also is a problem. Plus, only IVL doesn't work. You have to have either pre and post dilatation with other balloons and other modalities. So I don't think that we should take that as a single device sort of solution. So now what are the limitations of a conventional treatment non-IVL? Let us say we start with conventional NC balloon, a cutting balloon or a scoring balloon as we heard, and a rotational atherectomy also, which we saw. So basically our problem with conventional NC balloon is that the arterial stretch is there, there is dog boning, and if that is there, there are high chances of dissections, antegrade and retrograde, dilatation pressures up to 20 or 22 atmospheres. People can go up to pointer options, laser pointer, yeah. Can go beyond 24, 26, but not recommended. And but the advantage is it can be used both for pre and post. And it has the lowest profile amongst all the 3 OPN cutting or scoring balloons, or IVL balloon also. Can be used with wire inside branch and relatively less expensive if you were to talk about the cost, especially in our patients where most of them are non-reimbursed. So cutting balloon, low pressure range from 6 atmospheres recommended up to max 12 atmospheres. More chances of perforation than an NC balloon. Sometimes the blades and vessel entrapment can be there. Cannot be used in very complex.
বললাম তো এই ফ্ল্যাটে যদিও ফ্ল্যাটটা বড় ফ্ল্যাট এখন তো দামের সব জায়গাতেই দাম কালিন্দিতে যে ফ্ল্যাটের দাম তো ম্যাক্সিমাম 75
Please unmute besides the
can
speakers.
the technical team unmute so that we don't have disturbance. So cutting balloon cannot be used for post dilatation. It is expensive than an NC balloon and should not be used, or it's not recommended when you have wire in the side branch. Rotational atherectomy we have all seen, but in slow flow distal embolization and all those problems are there, but nevertheless useful device when nothing crosses. So the concept of a super high pressure balloon came in with the concept of dilatation force. And dilatation force is a function of inflation pressure and balloon material. So you have two balloon materials or two layers of balloon in a super OPN balloon to take care of the compliance part so that they don't expand too much or perforate. And the inflation pressures therefore can be taken up to 45, 50. So the dilatation force, the radial force exerted by the balloon on the coronary lesion or the metal stent is basically the inflation pressure when you have the right material. So what is OPN NC balloon? It is, as I said, a dual layer balloon, and therefore it has increased tensile strength and there is uniform expansion. The entry profile is 016 and the crossing profile is 028. With this, there are two markers, and yeah, so this is classical dog boning which we see with the NC balloons, and you can see this gets over expanded, whereas this is uniform expansion even at 35 and 40 atmospheres. And then if you see here, the growth in the balloon is 10% of the size which you have selected, even at 35 and 45 atmospheres. So that's very important to remember, especially when you are selecting the size of the balloon for the lesion, right? So you have a wide range, right from 1.5 actually to 4 millimeter. And as I said, 10%. So if you take a 3.5, it will go to 3.91. And if you take a 4, it will go up to 4.41 at 35 and 40 atmospheres. Now, this is the most important slide, I would say, for people who have less experience in OPN. So this is guide catheter compatible 6 and 7 French. Avoid polymer sleeve wires like Filter, XT, and Whisper. It will stick to it. And when you try to remove after inflation, when you have deflated fully, the wire along with the balloon will come out and you lose the access of your lesion. For accessing distal lesions, use extra support guide wires and like Grand Slam, All Star, or Cyan Blue extra support. Or for routine also, you should keep you should put it on an extra support guide wire. I would say keep another wire in case it gets stuck and cannot be removed. You at least have one other wire access, and this other wire also can sort of work as a scoring balloon. If you cannot deliver it distally because it has a high profile, just like the cutting balloon and the IVL balloon, then you can take the help of guide liners and Guidezilla or extension catheters. Now, if you were to use it purely for pre-dilatation, then use 0.5 millimeter lesser diameter than the reference vessel diameter. Now, this is very important because at 35, 40 atmospheres, as I said, there could be 10% increase, and the last thing you want is a perforation. For post-dilatation, once you have stented, then you can use 1:1 size, or in instant restenosis also you can use 1:1 size. Now you have a special inflation device which goes up to 55 bars from there. So it is OPN ID special. It comes along with the balloon. Increase the pressure gradually after you reach 20 atmosphere. So you reach 20 atmosphere to the nominal and then gradually go by either 2-4 atmospheres, wait for some time, see whether the lesion cracks or not. Once the waste disappears and the lesion cracks and the balloon is 1:1 inflated, that is the pressure at which you should deflate and not go further. Unless you are doing an instant dilatation. If that your repeat imaging shows that it is still under expanded, then you can again go. This happens in instant restenosis especially. And before you remove the balloon, in routine practice, you may not give a puff, but here you give a cine injection and check for perforation before you remove the balloon. Because if the balloon and the wire comes out together and you have a perf and you realize later on, then it will take some time for you to again rewire and take another balloon to do balloon tamponade. So this is very important. Check for perforation before you remove. This is classical NC balloon, dog boning. You use a high pressure balloon, some amount of waste is gone. And if you see here, there is a crack in the calcium fracture and which is also deep enough to go into the calcium. Another post-tenting you have done here, and there is dog boning here, NC balloon doesn't work. And even after you take a IVL balloon, though it is not advised immediately after stenting to take an IVL balloon, but sometimes that also poses a problem. The OPN balloon at 40-45 atmosphere will give you good expansion without complication. This is another case, OCT with stent boost, to show you under expansion, and an OPN balloon can help. So post stenting, if you have under expansion, no cutting balloon, no IVL balloon, first choice would be an OPN balloon, especially in instant restenosis also. ISAR Calc was one study with more than 300 patients, and where these were all selected patients, calcified patients without any good luminal gain, and waste were there. And here, if you see here, 43% of the lesions gave way between 30 to 40 atmospheres, and 50%, 57% up to 40 atmospheres, for more than 45. And if you see here, 15% had to go up to 46 to 50 atmosphere. So here, as I said, if you don't crack the waist, you can come down from 35, go again up, and next time you go to 40, again come down. The reason why I'm saying is, you check for perforation. Every time you deflate, check for perforation, go up again higher 5 atmospheres, again deflate and check for perforation. That would be a more safer way, rather than in the first inflation going straight, slowly, gradually up to 50 atmospheres. So these are about more than 500,000 patients, more than 5 lakhs. That is there's 500,000 patients being reported worldwide. Is it absolutely safe? Is it never there any perforation? Yes, there are perforations, but mind well, most of them are pinhole perforations. And if you see the difference, see the lower bottom, either in an NC balloon, it could be longitudinal axial tear, or it could be a circumferential radial rupture, one of these two. But this is the peculiarity of OPN, that by and large it is pinhole rupture, so that it doesn't give rise to any sort of antegrade or retrograde dissection or perforations, less common. So perforations are also reported with this. This was one where you had an eccentric nodule on this side. We used an OPN, gave up to 35 atmospheres. And then when we checked, there was a perforation. The waist had gone, but the perforation was there. Ultimately, we had to put in a stent graft, and therefore, always confirm the availability of appropriate size covered stent when you're going to use such kind of devices. So my last slide, limitations of conventional treatment. I started with conventional NC and cutting. With OPN, it can be used as an NC initially. So instead of using a separate NC and then a separate OPN if required, you take straight away your OPN balloon, use it as an NC initially for 20 atmospheres, and then if the lesion gives way, you did not have to go to the high pressures, put in a stent. If you get under expansion, the same balloon can be used for high pressure balloon dilatation. It's best when the 360 arc of calcium with or without nodule is there, but if you don't have 360-degree arc of calcium, and even without a nodule, be careful to go to supra high pressures, especially when you have 180 degrees of normal arterial wall. Can be used for pre, post, and in ISR. The sizes available are 1.5 to 4 millimeter. Unlike other cutting scoring balloons, 1.5 is also available with this. It is expensive than NC, but is almost as the same cost as cutting balloon. Can be used with wire in side branch or through the stent struts in a side branch. You can do a kissing balloon with this. The same crossing profile as cutting balloons, but has lower entry profile than cutting balloons. So that's an advantage. Thank you very much. And
thank you.
I'll be happy to answer questions. Of course, I have backup support of Dr. Hiremat and Dr. Kalra, so I'm not worried.
Thank you, Dr. Shah, for your excellent presentation. Yes, I'm sure that Dr. Kalra and Dr. Hiremat will be more than happy to join in. I was just wondering, you were mentioning about this as a first go balloon as well, instead of NC balloon, for stenting, before the stenting you can do. So,
No, I was saying you can use
possibility.
this Yeah, but the crossing profile, please remember, the crossing profile is as same as either cutting or this, but the entry profile is good. So you may take, suppose if you have a 3 millimeter vessel, you can go with 2.5 and then use it as a pre-dilatation up to 20 atmosphere like a regular NC balloon. And then if you see that the waist is not giving way, then you can go ahead. Instead of taking first NC balloon, waist not giving, then use an OPN balloon. You see, so maybe it may cost you. I mean, what I'm saying is the cutting balloon cannot be used both for pre and post dilatation, or a scoring balloon also. That's the advantage here.
Do you
And
think
neither the IVL also. You see, IVL also cannot be used for post dilatation.
do you think that when you are comparing IVL with OPN, I mean, for its use in disrupting the calcium, I mean, which one would you prefer when you have a circumferential calcium, a deep calcium, a IVL
See,
or a OPN?
there are two scenarios. One is an ideal world scenario, right? Where either the patient is ready to pay anything or the reimbursement is anything, limit, no limits, like they have in Western world, and Sanjog Kalra enjoys that benefit, but we don't have that benefit, honestly speaking, right? So one has to be choosy. So I always learn from cath labs which don't use IVL regularly, and I'll quote now, Dr. Florim Kukuli was other day in our webinar in a live case, and his uses more than 500 OPN balloons a year. And only if that fails, he says, I go to IVL, not because IVL is not reimbursed. Even IVL is reimbursed. But he says that I find this in 95% of cases, it is useful with hardly a single digit perforation, perforation complication or incidence. So I think we should know as Indians, what are the options available to us, and OPN is one such option. See, if you combine ROTA, OPN, and a stent and everything, it will be still cheaper than an IVL.
Yeah, I think I like your slide about, you know, how you tell to check for perforation before every removal of that.
Right, yeah, I have learned the hard way. I tell you, now I'm very careful. Initially, I used to go with that enthusiasm, like what the company people tell you, don't worry, 45, 40, and even in live demos I have seen, they go up there. But now with one perforation, I understood that we should be very careful in going with super high pressures immediately in one go.
Okay. I would like to take the opinion of our expert panelists. If you have any questions, Dr. Mondal, if you have any question, please.
So can
Oh, I think well discussed.
Yeah, Dr. Kathuria.
Yeah, just one important point: if you're using an OPN balloon, if it's for pre-dilatation, you must use 0.5 millimeter less than the angiographic appearance. While for a post-dilatation, if you're using an OPN, you can go to 1:1 ratio with the artery. For a pre, you must remember to go a little 0.5 millimeter less than the artery which you are seeing by an angiography.
Absolutely. That's why I said the most important slide was tips and tricks. Okay, that's very important, because initially in enthusiasm, you know, you take the same wire, you go over it, you get some complication, and then when you try to remove that, you lose the axis, and the artery is dissected, there is no stent there, and then you find difficulty again. So 0.5 millimeter less, even if you have a larger vessel, say for example, it's a 4 millimeter vessel, I would not go with a 3.5, I would go with a 3. The reason why I'm saying is that higher the size of the balloon, the expansion will be 10% of 4 millimeter, like it's 0.4, or 3.5 will go to 3.9. So don't do that. Take 3, because even if you get a 3 millimeter good expansion, the area is 7 square millimeter, which is generally sufficient enough. So I think when you go to 3.5 and 4, I would say don't take 0.5, take 1 millimeter less, get to 3 millimeter, get a good expansion. Then after stenting, do once this again high pressure dilatation with that 3 millimeter balloon, do a stent boost, check whether there is an under expanded stent. Even if you're not using imaging, you can check on the stent boost, and then decide to take an NC balloon with the appropriate size. You will get a good result by and large. If you have achieved 7 square millimeter, I think should be happy with it, because most of the FFR at 7 would be negative.
The
I think
concept
I
of-
agree with you, Dr. Shah, for your excellent teaching value for this OPN balloon. For constraints of time, we have to move on.
just one point, sir, just one point.
Go ahead,
Okay,
go ahead.
My only prerogative of telling this was that you don't size the OPN balloon with the IUS or an OCT. An angiographic estimation will be better in this case, because angiographic per se is 0.5 millimeter less only. In this case, angiography will correlate better as compared to an IUS OCT, where you go with the exact size and then you can you have more chances of perforation.
I agree fully. Be conservative in choosing the size of OPN balloon. When you are taking an IVL balloon, you can afford, because it is only at 4 atmosphere. Even though the pressures created by IVL is 45 or 50, but they are all micro pressures, and they don't give rise to so common perforations or so big perforations otherwise as compared to this. So I fully agree with you and your comment.
Dr. Shah,
Yeah, I
first
think,
of all,
yeah,
congratulations.
yeah,
very
Dr.
well
There
told.
you are.
Know,
I was
excellent. I
waiting.
am here
Where
only.
is Dr. Kali?
Yeah.
If it is Calcutta, it has to be Kali
I
there.
was there enjoying your lecture, VT. Excellent lecture. Really, I enjoyed it, and it was a superb lecture. Just
Thank
one
you.
question, VT. That
Yeah.
in under-expanded stent, sometimes this is a problem. We couldn't appreciate that there was so much of calcium, and the dilatation was done. The balloon also expanded, but after that, we find that the stent is little 10% or so under-expanded. How is your experience with this OPN? We often use OPN balloon to dilate a under-dilated stent, like you only. So what is your personal experience in getting success in such cases?
Okay. So you have to understand whether your stent has got stent recoil. If it is stent recoil, then whatever high pressure you go, you will see good expansion when the balloon is expanded. The moment you deflate, there is recoil. So then that is not the answer. So for that stent type of recoil, you might have to either, if the lumen size is good, as I said, more than 7 or 9, you might have to leave that 10 or 20% and come back. But if the lumen size is less than 5.5, as we say on IVUS, if the lumen size is less than that, we are sure that the FFR is going to be possibly positive. And in that case, if it is stent recoil, I'll put in a second stent and give a good expansion, because possibly the lesion is so tight enough that the stent is recoiling. But if it is an under-expanded stent with a waste which you are getting with an NC balloon, then please take an OPN balloon and get at least a good acceptable stent expansion of the size, at least more than 5.5, and 7 if it is 3.5 vessel, I would say, at least.
Yeah, we also do like that.
Yeah.
Just I was asking for your opinion. Yeah.
Very good.
And in
very
majority of the cases, we become successful.
Yeah. I mean,
Okay, very
everything
nice
boils
lecture
down
again,
to
PT.
cost.
Yeah.
I think everything boils down to cost, basically, because we always would like to have some cost-effective or economical solutions. But I think OPN is also a good. So, okay, there is one question from Dr. Kalra. He says, do you find such stent recoil is more common with the thinner struts? Okay. So Dr. Kalra, I mean, excellent question. I agree with you. And there are two situations I'll tell you where I have faced this problem. Okay. One is thinner struts, which is less than 70. What I mean is we have a 60 micron stent strut available in India here. And that if you use in calcified lesions like this, the chances are very high. One. And then the second thing, you may not have the BVA stent which is available in India, which is the Meres we have from Merrill over here. And we have started using, especially when the calcium is not there. And I do a CT coronary angio before I take these patients, ideal for Meres. Okay. And in one situation, I found that the area was 4 square millimeter where the artery size was 3+. And with super high pressures, all these balloons, our regular NC balloons at 26, 28 would not. Then last option, I took an OPN and I said, if this fails, I'll have to put in a metallic stent to get that recoil out. But fortunately, OPN did the job and I got more than 5.5 and I left it to that. So you are right, it is not only thin studs, but I think the BVS, if you use in such, you have to be careful. Anything you want to add? You on mute.
Kalra.
I am eagerly waiting for your presentation actually. I accepted this offer to give a lecture because they said Sanjog Kalra is after you.
Okay. So I think we'll move on then to our next presentation by Dr. Sanjog Kalra for approach and consensus in management of calcified coronary lesions. I think this will be a fantastic opportunity to hear from him, and he will be probably summarizing exactly what we should be all doing when we approach calcified lesions. So over to you, Dr. Kalra, for your presentation. Thank you.
Sir, we are unable to hear you, sir. No, sir, no.
Your microphone has got disconnected, I think.
I think this is better now.
Yeah,
Yes.
correct.
Okay. I'm sorry, I'm just having some trouble getting my screen shared. If you'll give me just a moment.
Sure, go ahead.
Yeah, it's coming. Very good.
Okay.
Got it.
Great. Thank you very much for your gracious invitation to speak while I correct the spelling error on my first slide. I really appreciate the opportunity to be involved in this conference. It's really well put together, and it's a privilege to be part of the faculty among such talented interventionists. Over the next little while, I'll try to give you a general approach to when to use what, because I think it's quite difficult to, amongst the large toolbox that we have at our disposal, to identify exactly what's right for what lesion. And I think the old way of doing it, which was if you see calcium, you have to treat it with something, is probably now given way to a little bit more of a tailored approach. These are my disclosures. So let's talk about an illustrative case that I got from Ajay. I thought this was such a really good case that it's worthwhile presenting. So it's a 70-year-old with the usual cardiac risk factors with stents deployed in the proximal and mid-LAD with some underexpansion. And she's got worsening angina. And then with RODA in 2017, including stent ablation, they were still underexpanded. And so she continued to have exertional angina. So here's what her LAD looks like. You can see the markedly tight, markedly underexpanded stent right there, that dog bone that you can see within the stented segment. It's something that gives us all nausea. Tried to IVUS it to try to define what the nature of the anatomy in that stenosis was, and the IVUS wouldn't cross, which is a common problem. So then we tried a 2.0 balloon, and that didn't cross. So then we tried a 1.25 balloon, and that didn't cross. Then after the 1.25 finally got in, and we did 6 inflations, then there was an NC quantum that was used at 30 atmospheres 4 times, and then another NCU4 after that one broke 2 more times. And now you couldn't get the 3.0 balloon past the proximal LAD stent because of stent deformation. Now what? Well, let's try a scoring balloon then, right? So we've tried a scoring balloon now, and that didn't work. So then finally, after 30 or 40 minutes doing this nonsense, somebody decided to take laser atherectomy, put it into the middle of the stent, contrast enhanced it, and then found that NC balloon expansion was achievable. And then with some wire manipulation, a 3.5 NC could be advanced, and then finally a stent was placed after some guide wire manipulation, and we achieved this final result, which is substantially better than the functional dog bone that we saw. But it took us forever, and it took us multiple balloons and a lot of time wasted in the cath lab. So can we do better than this, right? Is this a familiar scenario, the so-called rota regret? They'll recognize that this patient had rotablation already and had an ablated stent already and still wasn't getting good stent expansion. So what do we do for these patients, right? So talking briefly about the frequency and implications of coronary calcium, we know that coronary calcification is increasingly common, both because our patients are getting sicker, but they're also because they're getting older. And then interestingly, because I mean, in these older studies where they looked at the previous stents that we were using, first and second generation drug-eluting stents, where calcium was largely an exclusion, it still comprised almost 30% of patients out there. When you look forward into more acute coronary syndrome type trials, you know, this was an analysis of Acuity and Horizons AMI, which we're all familiar with. We see that 31.9% of acute coronary syndrome patients have important calcification, so moderate or severe, angiographically. This then tells us that we need to be ready to treat this with some sort of calcium modification technology because the patients are very common. Even heavy calcification in trials that we quote every day, the Syntax trial, where this was before the use of frequent intravascular imaging, before the appearance of OPN balloons, before the frequent use of orbital atherectomy, even these patients had 50% calcification in the heavy range. So it makes you wonder exactly what it is that we've achieved so far from an outcomes perspective and how maybe a rational approach to dealing with calcium could have improved these outcomes on the percutaneous side. We know that coronary calcification results in poor stent delivery. It results in decreased stent expansion, malapposition, stent asymmetry, wasted time, and then increases the rates of stent fracture. And this is where I was going with that comment about really thin strutted stents, where when you're taking ultra high pressure balloons in eccentric lesions, you genuinely increase your risk for stent fracture. And as a result, you force in-stent restenosis at those sites, not just because of the underexpansion, but also because you now have an inflammatory stimulus there. And then, of course, you have things like procedural complications. When you're taking balloons up at 30 atmospheres and they dog bone or they move or they watermelon seed and they move forward, then it's not surprising that we then injure the intima after stents, which is not always obvious. So you end up with those candy wrapper lesions 6 or 8 months down the line when the patient comes back with recurrent symptoms. So how do we detect coronary calcium now? And is there a better way to detect coronary calcium that can actually inform the way we do our cases? So when you look at this study, what they did was they looked at people who had angiographic calcification and they IVUS those people, okay? And when you looked at the intravascular imaging and compared it to the angiogram alone, what they found was that people with angiographically significant calcium typically had thicker calcium, okay? So it was more than 5 millimeters thick, okay? And more importantly, when they had large arcs of calcium, so we're used to talking about arcs, their arcs may be bigger, but they were bigger when it was invisible calcium angiographically, but obvious on IVUS. Whereas when it was angiographically visible, the less than 0.5 millimeter thickness of calcium was less commonly seen. These people typically had thicker calcium. So arc is important, but thickness is really important, that cutoff of greater than 0.5 millimeters. And this translated to differences in stent expansion, right? Where those with angiographically non-visible calcium, so thin calcium, had much better stent expansion than those with angiographically visible calcium in the absence of a calcium ablative technology. Okay, so this was balloon and stent, or NC balloon and stent. And the reality is IVUS detection of calcium has limitations, as was alluded to earlier, right? IVUS does a very good job of penetrating deep into tissues, but it doesn't do so well getting across calcifications. So when you have IVUS calcium, you can't necessarily measure thickness in all patients, only arc and length. And if we assume that superficial calcium is thicker than deep calcium, then IVUS becomes even less useful because now we know that the calcium we're seeing close by is thick. And we have no idea whether or not the typical technologies will allow us to move forward. So we need a more systematic approach to getting into this. Unlike IVUS, OCT, as was also alluded to earlier, penetrates calcium a little bit better. And as a result, we're able to assess the nature of the calcium a little bit better than just saying it is or is not calcified, or it is moderately or heavily calcified based on angiography. So what Akiko and her group did out of Colombia was try to look at patients who had OCT, IVUS, and angiography on the same patient, and they pulled the OCTs with these individuals, okay? And what they did was performed a multivariate linear regression model to define what characteristics on OCT were likely to predict good stent expansion in the setting of calcium. And what they found was calcium angles over 180 degrees on OCT successfully reduced the likelihood of good stent expansion, as did a maximum calcium thickness of 0.5 millimeters, as did a calcium length, so a length along the vessel of over 5 millimeters. This was on OCT. And from that, they developed a calcium volume index, right? And this was effectively a scoring system. So this was via the derivation cohort that they had in their study, where they defined an angle of over 180 degrees as 2 points, thickness of 0.5 millimeters or more is greater than 1 point, and a length of greater than 5 millimeters or more is 1 point. So total 4 points. So recognizing now this score of 4 points, did it work? Well, interestingly then, when they put this score into operation on the validation cohort from their study, which was equally matched in number, what they found was that indeed high CVI scores, so scores of around 4, the minority of patients were in 3. So scores of around 4 had lower target lesion expansion, more calcification, and a lower minimum stent area. So the score works, right? So when we look at calcium on OCT, we need to think about the angle, we need to think about the thickness, and we need to think about the length. But 180 degrees of calcium is not really all that much. So, you know, are we missing something? Well, when you look at calcium morphology with just NC balloon expansion, okay, without atherectomy, what you find is that the most important determinant is actually the calcium thickness. You know, the majority of calcium fractures were actually seen in these people with less than 0.5 millimeters of calcium thickness. So taking this and saying, well, you know, 0.5 is, you know, is sort of middle of the road as far as a number, and 180 degrees is traditionally less than what we've been thinking. Let's test this on IVUS, which is what people use more commonly because it's a more defined strategy, right? So they took just over 3,000 patients who had been IVUS, created a test cohort and a validation cohort, similarly to their OCT study. And with their multivariable linear regression analysis in this study, what they found was that the covariates that tended to predict calcification were in fact length of calcium greater than an arc greater than 270 degrees, the presence of a calcified nodule, so both of these reduce the likelihood of expansion, a vessel diameter, so how big the vessel itself was, of per 1 millimeter, so greater is better, predicted better stent expansion, as did the reverberation arc. So when you have reverberation arc in IVUS, the assumption becomes that that is in fact thinner calcium. These are natural reverberations that the calcium creates within the IVUS image, and that predicts a higher likelihood of proper expansion. So what they assessed were the vessel diameter, so the whole vessel, EL to EL in a non-calcified area, the angle or the calcium arc, the presence or absence of reverb, the presence of a calcified nodule, which as we've established is very bad, and then the length of calcium, okay, the length of that 270 degree arc. And what they found was that, again, the arc of over 270 degrees on IVUS, the vessel diameter of per 1 millimeter growth, the calcific nodule, the presence or absence, and the reverberation arc all had important predictive abilities, where if the length of your calcium was over 5 millimeters, you got a point. If your vessel diameter was less than 3.5 millimeters, so the bigger the vessel, the easier it is to get expansion, you got 1 point. The presence of a calcified nodule gave you 1 point, and the reverberation arc of less than 90 degrees. So remember, your reverberation arc is how much of these reverberations you get, because that tells you that the calcium is thinner in those areas. You got 1 point. And with that, the validation cohort, again, defined higher scores as less likely to have good stent expansion, with cutoff value of over 2 suggesting poor stent expansion, so less than 70%. So really what you need then is a 100% imaging approach to these types of patients with real cutoffs that you're using to define whether or not you're going to need ablative or non-ablative technologies. So how do we treat calcium? Well, what's the goal? The goal is a change in vessel compliance. What we're looking for is fracture. And so calcium fracture relates to outcomes, right? The more fracture you have, the better your stent expansion, and the less the calcium thickness, the more likely you are to get fracture. So as a result, do you need a rotablator for someone who's got thin calcium? Probably not. And so when we look at the treatment of calcific lesions and we look at the myriad of options that we have, we can consider cutting balloons, okay, where these athertomes create microsurgical incisions in the vessel wall, specifically the areas of calcification. And we know that when you compare cutting balloons versus conventional angioplasty, you get better cracks, you get better minimal stent area, and you get better vessel compliance with a cutting balloon. And these are best done in patients who don't have overly thick calcium. The rotablator, as you've all heard about, and I won't belabor much, is now starting to gain a resurgence, even though the overall adoption of this type of technology is well below where it should be, given that it came out back in the 1980s. There's been a recent iteration as a result of some of the other new kids on the block and new options on the market by the company that has made this a little bit easier to use. When I won't go over the IVUS or the Rotaxis evidence in too much detail, other than to say that with the presence of rotablation, you did get an in-stent late lumen loss at 9 months that was less than with just balloon angioplasty alone. And this was particularly pronounced in patients with severe calcification. Recognizing the time, I'm just going to push us a little bit quicker forward, but I'm happy to make these slides available. The ROTATE multicenter registry was a good one that looked at planned versus provisional rotablation. So that relates to our case. And what they found was that the ones where we did provisional rota, those cases were uniformly longer and the stent expansion was uniformly less good. And the number of balloons and the amount of material used was uniformly more when you did provisional rota. So if you have serious calcification with the factors that we talked about on IVUS, don't mess around. You're looking at an atheroablative technology. And for what it's worth, atherectomy plus cutting balloon angioplasty versus atherectomy alone seems to get you even better calcium fracture and even better stent expansion when compared with just the atheroablative technology. This is the Diamondback, or the orbital atherectomy device. This was studied in the Orbit 2 study and showed that similar procedural successes with good safety within the confines of the trial. When we look at the angiographic complications of this technology, which has found its niche largely in these vessels that taper a lot because you only need one crown. It's all about the speed of the crown rotation. And in those vessels that are a little more tortuous because it's a low profile device, so it's easier to deliver distally, that these individuals had relatively acceptable complication rates that were very similar to those seen in rotablator studies, the most common of them being dissections, which is, again, not surprising because you're modifying the intima. And importantly, the outcomes were similar to the major DES trials thus far, showing OAS DES TLR rates of about 4.7%. So the relative advantages of OAS over rotational atherectomy are the hardware and setup is very straightforward. The wire is made of nitinol. It's easier to wire with. It's lower profile and you're able to deliver a little bit more distally. There's also less likelihood of significant no reflow depending on, presuming you've used optimized techniques. With ROTA, it's better for aortoosteal lesions. You can adjust what kind of ablation you're getting based on the wire bias that you create by putting your wire in. You've got front cutting for uncrossable lesions, whereas with OAS, you don't have that. And it's known to be useful in ISR and underexpansion where you have to do stent ablation. There are some papers coming out with OAS and stent ablation, but I wouldn't recommend you doing that unless you have a fair amount of experience with the technology. And then, of course, you heard a lot about lithotripsy. I won't go over, again, the mechanistic details because that's not really the purpose of the talk. But ultimately, you do generate rarefaction waves of creating micro pressure phenomenon at up to 50 atmospheres within the vessel wall. They're best used in individuals with circumferential calcium, okay, to result in multiple fractures across the calcification, which can then result in favorable endpoints. And these were just the endpoints from Disrupt CAD3, where we saw that the various composite success rates, so procedural success, angiographic success, and importantly, device delivery was all quite high after the use of IVL, and that in-hospital and MACE rates were low. So this is the modern algorithmic approach. The bottom line is you need to understand what you're actually treating. It can't be just about is there calcium or isn't there calcium on the angiogram. You've got to image these people. When you've got uncrossable lesions or when you've got successful imaging assessment that defines those features that we discussed, so greater than 180 degrees on OCT or greater than 270 on IVUS, length of greater than 5 millimeters, thickness of greater than 0.5 millimeters, and a vessel diameter of less than 3.5, then you know you're going to want to use some sort of an atherectomy technology. Once you've done the atherectomy, look at your expansion. If you still have poor, consider lithotripsy. This is an Optima algorithm. It's very similar. right? So in individuals where you're considering lithotripsy up front, you can do that in patients with particularly larger MLDs where their calcification is truly concentric and it is truly circumferential, because that's where you're going to get the bang for your buck. Otherwise, consider your atheroablative technologies. But here's my simplified approach, and this is from Akiko as well. Do you have angiographic calcium? If you don't, even if it's there, it's thin. So just balloon it and stent it. If you do, and it's thin, use a scoring or cutting balloon, because we've known that you get good calcium fracture from those. If it's a tortuous artery, or if it's thicker, that's when you start thinking about your rota or your OAS. Your rota when you have non-tortuous vessels, where you have aortoosteo lesions, your orbital atherectomy when you have tortuous lesions, you have to deliver distally, or if you have a large vessel circumferential calcification. So, sorry, if you have a large vessel with circumferential calcification, use IVL. So we know that coronary calcium is important. We know that it's getting more and more common. We know that we have to have an approach to treat it. Intervascular imaging up front is very, very important to be able to define your best strategy. Thanks very much. And sorry about going a little bit over time.
Thank you, Dr. Calder, for your excellent discussion and presentation about how to treat calcium. And I like the last slide, it was very simplified. I think that's the way to treat calcium probably. Over to you, Dr. Kahali, for your comments, and then Dr. Shah, and then we can summarize our session.
First of all, congratulations as usual, Sanjog. Excellent talk. And you have told everything possible in such a short time. So really, it's a very, very good talk, and I liked it very much. We know that calcium is the Achilles heel in our intervention procedures, and many a times we fail to detect it properly. And we have got many answers now. And just I would ask you that what should you do in calcium nodules if you see in the OCT or IVAS, then are you going to do orbital atherectomy? There is no place for rotablation in those patients.
I think that's a great question. As we identified a little bit earlier in this session, the nodules are a real problem. My approach to calcific nodules, Dr. Kahali, is usually rotablation, because you have the imaging evidence, you understand where the wire is, you can understand how to optimize your wire bias, so that the likelihood is you get reasonable ablation of the nodule. And as we know, not all nodules are created equal, right? So there are the nodules that encroach the lumen to a small degree, right? Those are the ones where you're probably going to get reasonable stent expansion just by stretch of your adventitia on the opposite side. That's different than the nodule that's creating the majority of your stenosis, in which case you really have no choice but to approach it with an atheroablative technology. And typically what I would use in that situation is a rotablator, because I know that I can get the wire across, and I know that recognize that a lot of these are osteal, that I'm going to be able to get an even cut through the part of the nodule that I'm going to be addressing, and I can upsize burrs in that scenario. But I admit that we still get asymmetric stent expansion in those individuals, and that stent expansion is limited. The wrong thing to do is then take a 1-to-1 size OPN balloon and try to really bust it open, because that's how you end up with perforations. So we have to accept that that's still an area where we need to work on our approach and our technologies to be able to treat patients. We're limited there.
Thank you.
Dr. Shah, your final comments, and then we can ask Dr. Katuria to summarize the whole session.
Yeah. No, excellent review by Sanjog about calcified lesions. Now, my only comment is, depending upon the availability of the devices and the tools and the cost factor, I think the treatment of calcified lesions varies from country to country or region to region, depending upon, as I said, so many factors. So one has to develop his own algorithm in his own lab and decide, taking the help of all these international algorithms which are available. That is what I would say.
Dr. Prakash Mandal, your final comments, 30-second comments.
Can I follow that comment just for one quick moment? So I practice in Canada now, right, in Toronto. And so I'm in a managed healthcare system where money is not freely available. It's not the same as India, where patients are paying for their care, but we have to be aware of the monies that we're spending and spend them wisely. And so I am not a fan of throwing IVL into every calcific lesion, because it's ridiculously expensive for what you're getting, right? And that's why My approach to this, because I do believe that imaging is an upfront expense that is uniformly worth it. We have hard outcome changes based on imaging, that you're going to image them anyway. And so in the individuals where you've imaged them and identified reverberation and thin calcium, just take an NC balloon, crack it and stent it, you'll be fine, right? That's the cheapest, or I shouldn't say cheapest, but most economical and best supported approach by the data. As far as atherectomy technologies go, my approach to dealing with concentric calcification, particularly when it's heavy, isn't necessarily just about the calcium, right? Because you're right, when you take a rotablator, you're going to get reasonably good atherectomy. If you add a cutting balloon to it, sure, your cost goes up by $900, but that's fine. But if you have an individual who has poor LV function or who has a tortuous vessel, there's other factors that are going to limit the utility of an atheroablative technology. That factors into your choice to use IVL, so long as the substrate of the lesion is appropriate, right? So I think it's important to note that though I presented it based on imaging and based on the angiogram, all other things being equal, there's a lot more that goes into that. And I completely agree that these technologies are not free. And so we have to make sure that we use them appropriately. And I don't want to say sparingly, but we target the, the square peg to the square hole and the round peg to the round hole. And when nothing is needed, just balloon and stent.
Dr. Mondal?
Yeah.
Yes. I fully agree with you, Dr. Shah, because there is too much of regional variation regarding these technologies. If we think of this laser atherectomy or orbital atherectomy, it is not available in most of the cath labs in India. So we are more dependent on these cutting balloons and this rotablation and IVL. Out of these three, we choose interdependently which one is more suitable. Even after, suppose an impossible lesion, we usually treat with an rotablation, followed by, if required, with either IVL or with cutting balloon. So these three are mostly used by us. Rest, like laser atherectomy or vital atherectomy, we are not so much competent also, we are not using regularly. So this regional variation to be taken care of. And regarding cost, usually we go with rotablation more rather than IVL because it is still costly. It is not suitable for most of our patients because of cost limitations. So this cutting balloon and rotablation are our usual baseline practice. If it is too much needed, then we can go for IVL. This is the comment from.
Yeah. And don't forget
yes,
that sometimes surgery is cheaper than all this technology.
Yes, sir. I fully agree with you. Fully agree, because we are dealing with some patients where there is too much of cost limitation. So we have to think of cost also when we are choosing these technologies, and we will treat the patients with the available resources. So that is the last word. We have to keep in mind.
Thank you, Dr. Mondal. Dr. Panda, you want to put in your
this
last
is only comment, the BTCI, and to support the BTCI and the Cutler comment, that is also so many reports that is cutting balloon as well as the NC balloon is very, very equivalent result as of the rotor bladder. 85% cases. In my routine practice, 85% cases cutting balloon and NC balloon successful. Even I'm very reluctant to rotor bladder because of so many complications. The Cutler rightly, I think he's already agreed. In our circumstances in India, the NC balloon and some cases cutting balloon, modified balloon, sufficient enough, at least 85% cases to treat the calcium containing lesion. Okay.
Thank you, Dr. Paja. I think we had an excellent session. Over to you, Dr. Sanjeev Katoria, for concluding the session. Thank you.
I think couldn't have been concluded better by Dr. Sanjog himself and the comments from the stalwarts. Only thing to remember now is that with our armatorium having much more artillery with us, we should be able to understand that we'll have to actually balance between the financial status in India and the requirement. As Dr. Panja is also saying that we have 80% of the lesions which are responsive to our routine NC balloons and the cutting balloons. But of course, the new technology adds on to those 15% at least where you've not achieved a good result at all and you're waiting for a stent thrombosis. Then you're judiciously using them with respect to what kind of lesion is what we will all discuss. So I think it was excellent to talk about both the IVL as well as the opium balloon, both the new kits on the horizon. They've helped us.
Thank you to all the chairpersons and moderator and expert panelists and all the fantastic speakers. I think we will conclude our session and move on to our next session, and a very good evening to everybody. Thank you.
Thank you very much.
Good evening.
Thank you,
Thank you,
Sanjay.
everybody.
Thank you all
Thank
the
you all.
people and Icon.
Subhasish, I think
Thank
we
you
go
very
to
much
the
for the
Nightmare City session. So
Yes, sir.